dialysis is an excellent option when stage 4. So these are all again a cutout you can keep the recommended dosage for different anti-hypertensive agents in dogs and cats. You take a printout from your SWN and keep it in your practice. So now we are going to see the procedures: blood pressure monitoring, urine analysis, renal biopsy, peritoneal dialysis, CRRT. I'm not going to teach all procedures. I'm just going to tell you what basic procedures involved. So hypertension is a very common sequelae to renal disease. Majority of the feline and canine patients, the incidence of glomerulonephropathies leading on to hypertension is very high. Maladaptive increase in renin secretion leading to vasoconstriction, inability of the kidneys to properly excrete sodium and fluids because of declining number of nephrons, reason for increase in BP. Blood pressure greater than 150/95 mm on 3 separate visits in a patient with no clinical signs of blood pressure elevation, or a single measurement greater than 150/95 in a symptomatic patient, you can say it as a hypertensive. Animal exhibits signs of hypertension and you find 150/95 and take it as hypertensive. Systolic pressure approach 200 mm mercury. Your eyes, heart, brain, and kidneys start taking the insult. Therefore, they have to add them by treating them very aggressively. Hypertensive retinopathy and choriopathy, blindness secondary to hypertension, retinal detachment are all very commonly seen when the arterial hypertension goes more than 200 mm. Undiagnosed hypertension can lead to a significant deterioration in renal function as well as damage to other critical organs. Therefore, blood pressure should be measured in all patients who have been diagnosed with. So this is a normal Doppler blood pressure. We have again shown all the vets who have come to Lucknow. This one workshop, we have shown you this Doppler. This will somewhere cost you around 80,000 to 90,000 rupees, but definitely a must for veterinary practice, or at least senior practitioners who have a well-established clinic. They should include this Doppler BP machine. So this is a BP monitor. Doppler machine. It has a machine to pump air, and you have a cuff, which is very, very important, which is good. And then I'll tell you about how to keep the select the cuff. Whenever you buy a Doppler machine, you get a 5 or 6 different size cuff. So you should know what cuff to choose. The cuff width should be 40% of the appendage of the either forelimbs or hind limbs. I always prefer hind limbs. So whichever limb you choose, it should cover 40% of the circumference. That the breadth of the cuff should be, we have got a small calculation for that. Circumference, complete circumference of the limb into 0.4 is a cuff size. This is very easy for you to remember. Or you just have the breadth of the cuff. That should be 40% of the diameter, roughly. So you keep the cuff on the limb and see if it covers 40% of the limb, then it is you know that the size is right. If it is too small, go to the next size. The area, where do you do this one? Plantar area, metacarpal area. That is where you clip the hairs, apply the gel. You use ultrasound gel, not the ECG gel. So you need to conduct this one. So not the ECG gel, you need to apply ultrasound gel. So you keep the transducer in that dorsal artery, and you put the cuff and inflate it, and you start getting. Because I don't know that you get. So we have oscillometric method in human. Similarly, here also, when the moment the sound diminishes, then when stops, then you can measure the. Uh, so the probe can be applied caudal, metacarpal, metatarsal area. Next comes peritoneal dialysis. Peritoneal dialysis again, a procedure which can be definitely worth trying in all cases of acute renal failure. I personally would not advise you to go for chronic renal failure because the chances of complications are much more while you are putting peritoneal catheters. Therefore, I would suggest that you can make efforts of peritoneal dialysis in acute renal failure when you know there's a toxin involved, or when there's going to be a viper bite, or there's going to be some injuries which are very acute, then you can go for peritoneal dialysis. So the indications for acute renal failure, when blood urea is more than 100 milligram per deciliter or creatinine is more than 10 milligram per deciliter, and it is resistant to aggressive medical therapy like rehydration, osmotic or chemical diuresis, renal vasodilators, or for greater than 24 hours. So I already told you about what are the diuretics you can make, furosemide, or all those drugs not able to, and what are the drugs to use for inducing diuresis. All those things fail and you still have anuria, then you can go for peritoneal. Acute poisoning in which offending toxin is dialysible like ethylene glycol, phenobarbital, ethanol, or lily poisoning in cats, all these things. And viper bites, very, very important. Viper bites, they go for acute renal failure. But definitely you can go in for peritoneal dialysis. Severe metabolic disturbance such as metabolic acidosis, hypercalcemia, anemia, acute pancreatitis, uroabdomen. See, uroabdomen is another biggest problem which come in automobile accidents where the bladder is ruptured and you find urine in the abdomen. Of course, you can move the urine doing lavage, but still, dialysis will be much more useful in case of uroabdomen. Contraindications: abdominal wall trauma or peritoneal infections or peritonitis or severe catabolic states or ascites, recent abdominal surgeries. All these things you cannot keep catheter for volume extent because it depends why we are doing a peritoneal dialysis. There are a lot of peritoneal vessels which can exchange the fluids. They're like a membrane. It can exchange from the dialysis. It can take the fluid and send out the fluid to the abdomen. So that is the reason we are doing. So once you know the space is occluded for various reasons, abdominal tumors, ascites, all those things, then you cannot do peritoneal dialysis. So it should be done under a aseptic technique. You have to empty the bladder because inadvertently you can, because near the umbilicus, you need to put an incision and introduce the catheter and mid-caudal abdomen towards the pelvis. So there's a chance that you can rupture the bladder. So therefore, empty the bladder. Can instill 1% lidocaine. Small incision can be made and insert a 16 gauge through the incision. Use 10 ml per kg body weight fluid first. Place two stay sutures, then remove the 16 gauge catheter and insert the catheter, dialysis, peritoneal dialysis catheter. You have various types of peritoneal catheter available in the market. So all are very expensive for a veterinary practice. They might be very, very expensive, and there is a point. The expensive catheters, the more flexible they are, so they will damage. But the lesser the cost, they may be very cause injuries inside because moving inside the peritoneal cavity can cause laceration. The more expensive, the less the problem. Nevertheless, cost effective it should be. Therefore, we at veterinary college we have formulated using a Eurocap, which is used in human medicine. It is just costing you 160 rupees. Use them, use through that port stabilization of 3 to 5 centimeter lateral to the oriented towards the pelvis. After removing the 16 gauge needle, then you can put this Eurocap and suture them. And attach this Eurocap to a three-way stop cock. One, you can send the dialysis. Other, you can drain them without causing infection. So the peritoneal dialysis catheter towards the pelvic inlet, retract the stylet, secure it, attach it to a three-way stopper, sterile dressing, commercial dialysate with extrusion available, and you can add cephalosporin to the dialysate to start with, and maintenance you can add 250 milligram per liter. Also use aminoglycosides rate of 6 milligram per liter. Dialysate is heparin 100 or 500 units add the dialysis cycle. Usually the 10 minutes inflow time when you are introducing the dialysate inside the peritoneal cavity, it takes about 10 minutes. Then wait for about 10 to 20 minutes inside the peritoneum, and the withdrawal period from the peritoneum it can take about 30 minutes. In all, the dialysis cycle will be for about 60 minutes. Cycle of 50 to 60 minutes repeated for 2 times in a day, and the rate of infusion of dialysate 30 to 40 ml per kg body weight is the amount of dialysate you can inject. In chronic renal failure, about 4 to 6 hours cycle can be done, repeated 3 to 4 times a day. Alternate to commercial dialysate, which can be to make it cost effective, you can use Ringer's lactate with dextrose. You can mix 100 ml of D25 for every 1 liter of Ringer's lactate, 2.5% solution, or 60 ml of D25 in 1 liter of RL, 1.5% solution. These are all the alternate to commercial dialysate. You can use a mixture of Ringer's lactate and dextrose, which can be excellent dialysate. What are the complications you usually see in case of keeping a catheter, dialysis catheter? Catheter obstruction, they can get obstructed, exit site and tunnel infection, leakage of dialysate, electrolyte disorders, peritonitis, acute peritoneal effusion, hypoalbuminemia. These are all the complications you find in the PD, peritoneal dialysis. Next, we come to urine analysis. This is again a very important thing. The best would be to collect through a cystosynthesis, because the renal part of the solution or solute doesn't mix with the urine in misinterpreting the results. The cystosynthesis is an excellent option, but nevertheless, you can also catheterize and remove urine, most of the parameters. So again, very important in veterinary practice, we just, whether it is a blood or whether it is a urine sample, or how long we can keep in room temperature, how long we can keep in the refrigeration, what are the problems associated with storage in refrigerator or in the clinic. These are the most important things. Whole blood, or whether it is a saturated blood, or whether it is a EDTA sample, you should know what are the changes which can take place on time lapse between collecting and testing. So similarly, in urinalysis, you should test them within 1 hour. Delayed testing will result in reduced glucoses. So whatever minimal bacteria is present there in the urine, at least 3 to 4 cells per high power field will be there. Even them will reduce the glucose in the urine. And lysis of cast and RBCs, that can also take place because of delayed testing. So hematuria, you will diagnose them as hemoglobinuria. So by delaying the urine analysis, you understand, no? There'll be RBCs. By storage, they'll get lysed, and you will see only hemoglobinuria in the test sample. So the lab will tell you as hemoglobinuria. Increase in pH is there in delayed analysis, and therefore you test them within 1 hour. So no point in asking the client to keep it overnight and bring it the next day and things like that. Refrigeration is somewhat okay for most of the results, but one thing you should understand that it increases the urine specific gravity. So glycosuria and proteinuria, both of them impact urine specific gravity. So whenever you have measure urine specific gravity, you will have to take into consideration whether the sample has got glucose or protein in them. Then determines urine specific gravity determines the hydration status of the animal. So along with the total proteins, it tells you whether the animal is hydrated or whether it is a problem. It also assess the renal function. An adequate ultrasonograph hypocystinuria is 1.030 in dog and 1.035 in cats. Okay. The ultrasound, urine specific gravity of 1.008 to 1.012. The normal renal function is mostly because of dehydration. So recheck them after hydration. Don't jump to conclusion that it is, dilute urine. Okay, and don't diagnose them as renal problem. You have to hydrate them and redo the urine specific gravity so that you come to your realistic. If acetylemic, it's if you find 1.008 or 1.012 urine specific gravity and the animal is having acidemia, burn and creatinine are elevated, then it is a clear diagnosis of renal failure. If urine specific gravity is less than 1.008, then you have to consider extra renal causes of renal problem. Okay, it can be a cardiac case, or it can be an hypovolemic case, or it can be purely a disorder of fluid therapy. They can cause extra renal problem, can cause a diffusion, perfusion problem to the kidney, a low urine specific gravity. Inadequate urine concentration. I told you more than 1.030 to 1.035 is a normal specific gravity. Inadequate urine concentration you find in renal failure, prolonged diuresis if you are doing prolonged diuresis, diabetic insipidus because of ADH, osmotic diuresis because of giving excess glucose and mannitol, Cushing's or excess steroids given by vets, hyponatremia, hypochloremia, low urea, hepatic disease or hepatic shunts. They all can cause inadequate urine concentration, nephrogenic diabetes insipidus. All these conditions, you will have inadequate urine concentration. So you will have a less than 1.010 specific gravity. Next, proteinuria. Proteinuria, I told you, proteinuria is a hallmark of renal disease. So, determine urine protein to creatinine ratio and assay of urine albumin concentration for microalbuminuria. It's also thought as earliest marker for renal disease, microalbuminuria. So persistent proteinuria with an inactive sediment is hallmark of CKD. That is very important. In CKD patient, you don't get hyaline cast. That itself, that means there's a renal shutdown and there are no cast. Persistent proteinuria with an inactive sediments is hallmark of chronic kidney disease. Microalbuminuria, intraglomerular hypertension, or vascular disease. So, how do you localize the proteinuria? Exclude extraurinary post-renal. That means evaluate urine obtained by cystosynthesis. If you are using a catheter, then it can be a urinary protein. So it can be because of myoglobin, or it can be due to hemoglobin, or it can be hematuria. Any of those things could have caused a protein in this one. So you have to rule them out first step by doing a cystosynthesis. Step 2, exclude pre-renal, evaluate plasma protein concentration. Of course, you do erythrophoresis. Yeah, dysproteinemia disease in dogs are very, very rare. So I wouldn't say this step 2 is so important to evaluate pre-renal and exclude them. But nevertheless, for subject-wise, you should think that dysproteinemia can be a cause of protein in the urine. Step 3, to rule in urinary post-renal, find evidence of inflammation or hemorrhage. Okay? Post-renal inflammation or hemorrhage, so that you know it is because of protein is because of post-renal problem. Then to rule in pathologic interstitial renal, find evidence of inflammation associated with clinical signs of active nephritis. Functional renal, pathologic tubular renal, pathologic glomerular renal, whether it is renal or tubular or glomerular, then you'll have to rule in all of them by seeing for evidence of associated with clinical signs of active nephritis. You have azotemia, you have dehydration, you have creatinine urine protein ratio is elevated, then you have proteinuria, then that is step 4. So functional proteinuria associated with hyperthermia, okay, fever, strenuous exercise, and history and physical examination generally indicate recent exertion or hyperthermia, usually mild and transient. This proteinuria is mild and transient. Okay, pathological, it can be pathological proteinuria, can be pre-renal or renal or post-renal. So in either of the case, it can be pre-renal proteinuria or post-renal proteinuria or pathological proteinuria. So pathological proteinuria, firstly identify the most likely source of proteinuria, that is exclude post-renal origin and look for indications of a pre-renal source. Secondly, determine if it is persistent, the hallmark of renal proteinuria. So you should do on 3 or 4 occasions and you should have a persistent proteinuria. Okay? Preferably using a urine protein creatinine ratio. That is the most important thing to diagnose a pathological proteinuria. Pre-renal proteinuria, urine analysis is not usually prioritized in patients suspected of hemolysis or significant muscle damage. So proteinuria is typically a coincidental finding in these cases. Okay, so that is pre-renal because of hemolysis. Again, post-renal is when again you'll have to see pollakiuria, all those clinical signs of straining or stones, all those things will be there in post-renal proteinuria. Step 5, to rule in pathologic glomerular renal. So for that, your urine protein creatinine ratio is very important. More than 2 dogs and cats, you can think about pathological glomerular renal proteinuria. Step 6, to rule in functional renal. The proteinuria is mild and follow-up evaluation to be transient. So if it is going to be vanish, the next time, then it is a transient proteinuria. 7, to rule pathologic low grade or pathologic tubular renal. The proteinuria is mild but proves with follow-up evaluation to be persistent. So these are all the 7 steps to find out where the protein is from. Next is renal biopsy. So it helps in altering patient management, especially in glomerular nephritis and acute renal failure in young patients, and especially if it is not more than stage 2 of chronic kidney disease, then renal biopsy can be. Contraindications, presence of an uncorrectable coagulopathies, we cannot do because there will be severe bleeding infarct. Severe anemia, hydronephrosis, uncontrolled hypertension, All these things are contraindication for renal biopsy. Large or multiple renal cysts, perirenal abscess, extensive pyelonephritis, end-stage renal disease, all these conditions you cannot do a renal biopsy. You can do a percutaneous blind biopsy, better suited for cats than dogs. Even dogs also you can do in this, less obese dogs, thin abdomen dogs. You can always push the kidney towards the abdomen and secure them and take a biopsy. There's no that. You can do a laparoscopic biopsy. You can do a keyhole technique. Best is ultrasound guided renal biopsy. Or you can do, if you are doing a small laparoscopic incision and do a wedge biopsy, you get a bigger mass for doing better histopathological evidence. Biopsy of the renal medulla, risk of creating large areas of infarction and fibrosis. It should never enter into the medulla. It should be only in the cortex. The cranial or caudal pole of the kidney, it will involve only the cortex. In the dog with generalized renal disease, the right kidney is often preferred over the left kidney. Easily available for palpation and general anesthesia is required. Machine has 18 gauge needle is 9 centimeter length. You can use this specimen, or you can use a true cut biopsy needle with a gun. True cut biopsy needle with a gun, the technique of doing a biopsy is much easier when you are using a biopsy gun. Of course, it is expensive. It must be costing not less than 600 to 700 US dollars, a biopsy gun. The biopsy needle is very cheap. It is, chemically sterilizable and it hardly costs about 600 to 700 rupees, which you can reuse them. Pediatric, and you have several options. True cut biopsy needle, but a Mahogany needle or true cut biopsy needle. But the right side lower one is the needle plus the gun. You just have to keep the needle inside the gun and shoot, aim and shoot. So this is very, very easy, but at least the referral clinic can definitely buy a biopsy gun. Very easy to take liver biopsy, renal biopsy, or any tumor biopsy, anything. You just have to load the gun, load the needle, biopsy needle, that pink color one, load it in the gun, and then shoot. So otherwise, it's a very skillful procedure. Moving the front and moving the outer cannula, then moving the inner cannula, then again moving the outer cannula. It requires skill and practice to use a biopsy gun to take a biopsy. So with a gun, you can do it, with even a layman can do it. So this is the correct way of taking, instead of entering into the medulla, only the cortex you can do. If you enter the medulla, then you can cause severe damage, and you can cause infarct, you can cause bleeding. Therefore, it is done in the cortex. Percutaneous biopsy using ultrasound guidance is an easy method in small cats and small dogs, or fairly thin abdomen dogs. You can easily do with the right kidney. Minimally invasive with a swan, make a small incision and laparoscopic incision and take. Of course, post-biopsy care, isotonic fluids kept relatively quiet in hospital for 24 hours. Packed cell volume should be evaluated because of bleeding. Dog should be walked only on a leash for 7 hours. Color of urine should be monitored in case it is, hemorrhagic, then, it is inadvertently caused hemorrhage. not bother about all these complications which are, there in any procedure. You have a lot of complications like, I don't know, perirenal hematomas, cyst formation. With any kind of biopsy, you have this complication. But if you look at the list, such a long list, and you will be tempted not to try this renal biopsy. That is the reason I'm not trying to reach all these patients. For getting the complications, renal biopsy is a very easy procedure which can be easily done on an outpatient basis. Next is the hemodialysis. This, of course, I don't want to go in too much elaborate on this because the principles of hemodialysis are not required for practitioners. But what I generally suggest is hemodialysis is good for a referral practice. Those who are having a very good practice in the center of place and cases are being referred, they should definitely have hemodialysis, and especially for acute renal failure. The dogs coming in with acute crisis, shock, or automobile accidents, or poisoning, or viper bites, all those things can definitely be saved by using the procedure. Indications are refractory azotemia, tractable uremic signs, hyperkalemia, fluid overload, severe metabolic acidosis. So even in fact, we have done a small master's work at Veterinary College on this one, leptospirosis. The dialysis removes the even the parasite. So we are able to demonstrate the parasite, the dialysis fluid after removing it. So such is the effectiveness of hemodialysis. Even it crosses the membrane and comes into the filterable part. Acute poisoning, all those things, yeah, it's an excellent option to do. So again, principles are all not required. So the whole, the blood has to go out of the body and to the get, dialysis and then come back, enter into the. So essentially, you'll have to make a jugular cath, central vein, and through which it goes to the machine, gets dialysis and comes into the. So of course, nowadays the machines are very smart and they have all systems where it takes care of the leaks and things like that. And you have heparin being on automatically into the system. All those things are not a big problem. Once you have a machine, those things are all easily done. You'll have to connect them to your central vein. Yes. The only issues with that is minimum weight of the dog must be more than 20 minimum, because it's not sustainable. If it is smaller than that, life can't go on with all the blood going out of the system into the machine. So that is not possible. So you have to, you can try hemodialysis only in bigger dogs, and especially definitely not in cats. So again, you have ready-made dialysis available for hemodialysis. So you don't have to worry about the composition of dialysis compound. You are not going to make all these things. It's available, commercially available. Next is the continuous renal replacement therapy. This is an excellent option, but the cost is much more than hemodialysis because this will cost somewhere around 12 lakhs. Not only the machine costs 12 lakhs, the consumables for each patient will cost not less than 6 to 7,000 rupees. All those, dialysis, all those tubings, all those things are. The only advantage of CRRT is you can do in a small patient. You can do in a dachshund, you can do in a Spitz, you can do in a terrier, you can do in a cat, because it does piecemeal dialysis and sends back the blood. So the possibility of having complications are few with CRRT, but the cost involved in having a CRRT, those people who are having hemodialysis, they can think of having CRRT because the cost is around 30 to 40% more than hemodialysis. So continuous renal replacement therapy is about 30 to 40% more costlier than, but you can do in all patients and it does a better job than hemodialysis. So advantages: use cage side, use packaged fluid, no special equipment maintenance, monitor until normal kidney function is regained. These are all the advantage of this methodology. Only thing it is expensive. Even many of the hospitals, even corporate hospitals, do not have CRRT. Only few hospitals have CRRT. So this is a renal replacement machine we have at our college. So this is one of the finest machine we have that we've been doing in very small dogs. Again, the indications of CRT also is similar to hemodialysis. So it removes most of the drugs also, all the toxic drugs like cephalosporins, aminoglycosides, everything it removes. Okay, now before I forget, I just forgot to tell you about nutritional thing, which omega 3 PUFA, polyunsaturated fatty acids, very, very, very important for renal disease from all stages. Whenever you are putting a dog on renal diet, you have to put them on omega 3 polyunsaturated fatty acids, PUFA. 3 omega PUFA you have to put along with renal diet. And it's easily said, than done in practical, because acceptance of a dog or a cat for readily going in for renal diet is very, very difficult because low protein. Because you should understand the dog's tongue and the cat's tongue, they have fewer taste buds, and those taste buds also differentiate protein from non-protein, not different proteins. Okay, they cannot differentiate between potato and fish. All those things are not possible. They know whether it is protein or non-protein. So mostly when the protein reduction is going to be very much reduced in the renal diet, these dogs are not, cats are not going to take. Abalone dogs, cats are not going to touch. So the gradual changeover of food from normal diet to renal diet should be done in a slower fashion. You can go for resources, renal reserves, all those human available sachets are available to start with, instead of starting with renal diet. Afterwards, you can mix the renal diet with normal diet, slowly replace renal diet for chronic kidney disease. Any in to wind up, what I want to say is acute renal failure and chronic renal failure are a common finding in our veterinary practice. So first thing we need to find out renal failure or chronic, and what are the things which are required is one creatinine. You have SDMA, of course you can do SDMA. You have a small protocol for SDMA, just slightly better than because better than creatinine, because it doesn't involve other proteins which can cause increase in creatinine. Those things are not there with the SDMA. It's very specific to renal, but those who have got SDMA can do this. Urine protein creatinine is very important. Urine protein is very, very important. Urine sediment is very important. Analysis is the most important part of diagnostic part of renal disease. Along with that, most important is measuring BP, blood pressure. Require definitely BP apparatus. Stage the disease, which is going to see the prognosis of the disease, which is going to see the improvement in treatment, and it is going to save the crucial end organs of hypertension from deteriorating, like sudden onset blindness, retinal detachment, all these things. So all those things you require definitely BP apparatus, urine analysis, BP apparatus, and using antihypertensive drugs like amlodipine, enalapril, benzapril, adrenaline. Can use beta blockers. All these drugs can be used for hypertension, and treat hydration, steroids, avoid overload, and once you know is hydrated, go in for lesser volume of fluids. All the fluid therapy is very, very challenging in renal failure. Okay, inadvertently you give. So these are the nutshell of CKDs and AKDs.
Sir, there is one question. How to?
Hyperkalemia.
Yes.
Hyperkalemia, you will have to use glucose and insulin. Hyperkalemia, you will have to use insulin and glucose. They drive the potassium into the cells.
Okay.
Glucose and insulin.
Glucose and insulin
Yeah.
for hyperkalemia.
So that drives the potassium into the cells.
Any other question?
Good evening, Dr. Nambi, for such a wonderful lecture.
If you
Dr. Nambi, I want to ask what should be our preference, amlodipine or talmisartan? And
uh,
what should be the dose rate of amlodipine and talmisartan
see,
alone?
you
And
are
what should be if we use both?
no,
Thank you.
you see you have to use amlodipine first, and once you don't get a good response, then you can go for amlosartan or omlosartan. All those things you can think about later.
Okay, first we should think about amlodipine only.
Yeah. Amlodipine is a better. Even first you can even go for enalapril.
Doc, sometimes we use enalapril or benzapril.
Yeah,
Sometimes it's don't give good results. Then we add amlodipine.
yeah, correct. You're right.
Okay, okay. Thanks a lot, Doc. Thanks a lot.
Sir, one is it advisable? What is the advisable antibiotic for CRF?
Continuous this one, no, CKD, right?
Yes.
CKD you can use when you are potentiated amoxicillin in a lesser dose.
Yes.
Yeah.
I use amoxicillin potentially. Yeah. Next is a little bit more on SDMA.
See,
Okay.
CKD, you know, see, it's a very sensitive and early marker for reduced glomerular filtration in dogs and cats. Okay, more than 20 milligram per deciliter is kidney disease is very possible. Okay, investigate underlying cause, and urine culture and all those things. You do ultrasound, all those things you have to do once it's more than 20 microgram per deciliter. Okay, measure hydration status, BP, urinary protein creatinine ratio, all these things, and then treat for CKD once you have more than 20 microgram per deciliter. Okay. Then monitor, supposing it is less than that, monitor STMA, whether it is normal, whether it is stable but increased, or whether it is increased. That you will have to keep monitoring regularly. Like creatinine, how you market, same way here also you'll have to keep monitoring whether it has become normal. Just 1 minute, just 1 minute, just 1 minute, 1 minute, 1 minute, 1 minute. Okay, you'll have to keep monitoring regularly, and SDMA 15 to 19 microgram per deciliter. Then you try to find out other evidence through ultrasound, everything. Okay, so you'll have to keep monitoring regularly.
Okay. Dr. Hariratha GS Yadav.
Yeah,
How about incidence of CKD in age group of 2 to 3 years?
it can come, no? It can come. Leptospira infection can you can get. See, any acute kidney injury can go on to chronic kidney injury if it is not treated properly.
Any use of N-acetylcysteine as antioxidant agent in renal patients?
Yes, definitely, N-acetylcysteine also is being used, but
Okay.
they don't come into the protocol of regular treatment protocol of different stages. But definitely, N-acetylcysteine can be used right in various diseases as an antioxidant.
Uh, Pantoprazole can be used, sir, for metabolic acidosis?
Yeah, you can use pantoprazole.
Yes. Now I think there are no lot more queries. No other queries are there. And if somebody wants to ask anything, they can connect to me. I can forward your questions to Dr. Nambi. And according to his convenience, he is very generous and he answers all the queries what I have seen in recent past. So you can pass on all the queries to me. And here before ending, I would like to tell you something that Oriheal Life Sciences manufacture almost 100 plus pet medicines. We manufacture pantoprazole 20 mg and 40 mg. We make Benazapril 5 mg and 10 mg. We make ondansetron tablets 8 mg and ondansetron oral suspension we make. And we have a star product that is Nephrocare Advanced, which is a unique combination of 14 herbs for mainly CKD and urinary bladder and kidney stones. So, if somebody wants any samples or somebody wants to inquire regarding that, Kanika's number is always there on display, and you can connect to our team. And thank you very much, Nambi sir. It was whenever I listen to you, I find two or three more new things. I listen your this lecture in the Veticon also,
Yeah.
but today you have added on many more things for our participants. And thank you very much, all the veterinarians, for staying here on a busy schedule your Sunday evening. And this is the magic of Dr. Nambi, that students always want to learn from him.
You are giving me so much opportunities. Thank you so much for that.
Thank you, sir. Thank you very much. And Happy New Year, everyone, in advance, because we are not going to have any session in this year left. And coming up with a more exciting series with Dr. Nami and other renowned professors from the month of January. See you next year, same time, same channel. Thank you very much.
Okay, thanks everybody. Bye bye.
Bye bye. Bye bye.
Okay, thank you very much.